Thank you very much. A pleasure being here again amongst esteemed colleagues and panelists. And it's always fascinating to look at pediatric VR cases as well. So until we get my slides up, I'll tell you a brief history about my patient. So she's an almost 60-year-old lady who had a full thickness macular hole, and she underwent surgery elsewhere about 1 year before she presented to me. And when she presented, she had a dense cataract. And unfortunately, the macular hole, not only did it not close, but it actually got bigger because she had her baseline scans with her. So I'll start by playing the video. Now, in my mind, I had two options. I'll play the video and then I will leave it up to our esteemed panelists to discuss. So I started with my cataract surgery, and in this case, I decided to do quite a large oval capsular excess because I was intending to use the lens capsule as a free flap to cover the macular hole with. I don't usually do such a large oval capsular excess, but especially for this case, I decided to make it a bit larger than my average because I didn't know how many attempts I was going to need to be able to stick this flap over the hole. And obviously, the larger the capsular excess, the more tissue I have to be able to manipulate and use. So in a few seconds, I shall complete the rhexis, and then we get into the fun part. Now, I tried to remove the rhexis as one whole piece again, very gently, and I was successful in doing so. And I kept it in a clear pot filled with BSS. Now, after inserting the first two trocars, I do a small peritomy and after that, I put the third trocar through that because I'm planning in my head to remove the trocar, as I mentioned to my dear friend and colleague, Dr. Qahtani. I'm going to remove the trocar and I'm going to insert the flap with the forceps through the bare sclera as to avoid it being damaged through the trocar. And I obviously insert it obliquely parallel to the limbus just in case I was going to extend it. Now, as you can see with the blue dye stain there, you can see that my previous colleague, the previous surgeon, had done a very good peel. He'd almost done it almost arcade to arcade. And there were some edges of ILM. I tried to peel them. They were quite fragile. I know some people advocate to get another ILM flap from the peripheral ILM. It's not easy. I've tried it many times. It's not always that easy. So I do a bit of a massage around the hole with a very soft silicone tip. Now, as you can see, this is the capsule that I took, and I'm holding it in one hand with the forceps, and I'm using a micro scissors to cut about a 2 by 2 millimeter flap. Now, I've done a partial air exchange here. As I go in, look at what happens to the flap now as it touches the water. It basically spreads back again. So when you hold it with the forceps, it will crunch. But don't worry. As soon as it touches water again, it will spread. I use a bubble of PFCL and I inject it away from the flap, and I rotate the eye to get the PFCL bubble to come and cover the flap. I had a very, very small pre-retinal hemorrhage there from the massage. I'm not worried about it. In fact, the pre-retinal blood in this case is helpful. And then I drag the flap over the hole. And this is the OCT before the surgery. The base width was about 1300 microns. I'll show you the OCT scan about 3 weeks after the surgery. It's coming up right now. I might just forward to it. Here we are 3 weeks after the surgery, and the last time I saw her was a few months ago, and this was about 11 months after the surgery, and this is her OCT. Her vision actually improved from hand movements. Her best corrected visual acuity at her latest visit was 0.4, and she subjectively mentioned that the central scotoma was still there, but it was much better than before. Thank you very much. Now, I will leave it to our esteemed panelists for an open discussion. I know some of you may prefer to use the amniotic membrane. Personally, I'm not a big fan of amniotic membrane, especially down the line, long term. It just looks out of place in the macula, and you can get some fibrosis around it. And when I put the capsular flap down, I put the epithelium side down towards the retina, so as it's the same anatomical position as it would be around the lens. I don't know if you have comments about that.
Thank you very much. We can open the floor for discussion. I may start with the first question. Why not free ILM flap?
Because simply I couldn't. I tried to get a free ILM flap. The ILM was very friable. I couldn't get a big enough flap to easily remove and put the hole. I've done it before in some cases, and ideally it would be the best flap to use because it's the anatomical tissue there, but it's not easy in all the cases.
Okay.
Thank you, Dr. Zeid, for a very nice case. Whenever we use the lens capsule, it will raise or pop up the question of long-term gliosis or post-operative. For me, I don't have an experience because I don't use the capsule. But what's your experience in getting late gliosis?
Yeah. I mean, I've only had a few cases that I've used lens capsule in. This is one of the longest follow-ups I've had, almost 11 months after the surgery. And as you saw on the OCT, there wasn't any gliosis.
How would you know the epithelial side from the stain?
So it's not easy, but as you do the rhexis, basically the capsule will fold up. Okay, so as you're doing the rhexis, the capsule will fold up. And when you place it in the water, when you place it after you take it out of the eye, basically with the forceps, make sure the orientation of the forceps stays fixed. So when you hold it from the inside of the eye out, place it in the water in the same direction. It's not an exact science. It's not an exact science, I know, but that's the best way I could think of doing it.
Yeah, maybe you can take the last comment because just we need to keep the time.
How to maintain the cutting of the macular hole after removing your small bubble of, let's say, and hair. As you know, it's very easy to remove it when you remove your tertiary. The flap go easy.
It can move. Absolutely. Fantastic question. Thank you. In this particular case, because there was a small drop of blood, I think it acted as a glue. In other cases, what I've done is I've put viscoelastic under the PFCL. So I put the PFCL bubble, the flap is over the hole, yeah, and I come in with a long straight cannula, put a bit of viscoelastic, and then remove the rest of the fluid and the PFCL.
And do you have any investigation by cutting on the segment of the scapula in front of the macular holes? It's a risk.
Again, a fantastic question as well. Until now, I haven't seen, and in the published data about the few cases that have been published, none have mentioned the opacification, but you are absolutely correct. It is a risk.
Thank you, Zeid. Thank you very much.
Thank you.
We need to move on.